Today it's going to be, the topic is going to be adrenal fatigue. Is it real? And why it should be an accepted medical diagnosis. I'm Dr. Martin Rutherford. I am a chiropractor. And since 1979, I'm a certified functional medicine practitioner.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And then, as many of you who've watched know, and those of you who don't know, we have a chronic pain practice. We've had it for quite some time now. I know Dr. Gates this is your 7th year here.
Yeah.
And we were putting it together a little bit before that. I've been interested in chronic pain since like 1987. This is our share with you. This is what we do. We sit here, we share. For those of you who may not be aware, we attach references. I think you said you have 45 references attached to today's protocol or today's broadcast because this is a very important topic. I had it was a couple of years ago where you and I were sitting here and a fellow practitioner in Reno decided he was going to become a functional medicine practitioner, to which we applaud. And but came in and his first comment was, "Can't fix anything unless you fix the adrenals, right, Doc?" And Dr. Gates knew better than to say, "Don't say anything, don't say anything," because the adrenals are kind of the mantra, the touchstone, the holy grail in the alternative healthcare world. And although I've done an article that said the adrenals the wrong target, it's not because they're not a factor.
Right.
It's just because they are affected by so many other things, and it's hard to fix them if you haven't fixed these other issues. And we might talk about some of that today. But the adrenals in and of themselves are a very, very important topic. We're going to talk about today well, why don't I let you do the overview because you put this together. We're going to talk about the adrenals today. We're going to talk about their effect on virtually all physiology. We're going to talk about their effect on the brain and certain psychiatric type syndromes that maybe are your adrenals instead of being a psychiatric type syndrome. We're going to talk about some of the effects on physiology. It's a huge part of what we do in functional medicine. You're basically assessing the patient's situation, their symptoms, their physiology. You're looking at multiple different feedback loops, multiple different organ systems involved, multiple different biochemical pathways involved, all of which sounds very complex, and it is. And if you're going to tease out which ones are the main vicious cycles or which one are the main organ systems involved or pathways involved, the adrenals tends to float to the top more often than not as one of the big players in perpetuating chronic pain. Would that be fair to say? That would be
correct. Yes, that would be correct.
That would be fair to say. Okay, and so Dr. Gates, we've been playing around with the adrenals for a long time.
Yes, yes.
and ways to calm things down in people's physiologies. And so today we're gonna share with you some of the things that we found. But the fact that it should be an accepted diagnosis. Most people that come to us have been to their medical doctors, maybe after they've been to an alternative practitioner, maybe after they've gotten an adrenal stress index test done, as we can mention what that is, and they get the diagnosis from the alternative practitioner of adrenal fatigue, and then they go to their doctor, and the doctor says,
"Oh, it's a bunch of hooey."
It's a bunch of hooey.
Exactly.
It doesn't exist. There's no such thing as adrenal fatigue. 3/4 of the country probably has it.
Including all the doctors.
Including all the doctors who are telling you that they don't have adrenal fatigue. But it doesn't exist.
I think that should be another hangout. Why your doctor has adrenal fatigue.
Okay.
I'm serious. I think we're going to do it. Maybe next week or the week after.
Okay, all right.
But you illustrate a great point because they're diametrically opposed. So you have the alternative community, they're all about adrenal fatigue, like you're saying. Then you have the medical community just saying it completely doesn't exist. And I think it's largely the medical community is saying that because of some animosity towards the alternative community. It's neither right or wrong. It's just there. They don't. The medical community doesn't want to really hear from the alternative community what they think they should be doing. And so I think that's really the impetus for the problem with
they
the
understand
adrenals.
there's a problem.
Yeah,
There's no shortage of Xanax and Prozac and all that other stuff flying around.
And the data's there.
So they understand there's a problem.
Mm-hmm.
They just don't want to give us any credit.
True.
We're not anti-medicine. I know it's
That
going to sound like that
also
already.
true,
Okay,
yeah.
let me just say, for any of you who watch that, we say it every time. We work with neurologists. We work with internists. We work with functional psychiatrists. We work with everybody. We've worked with cardiologists. We've worked with everybody. We worked with everybody. We have a good working relationship with the medical community, believe me. But we need to be real.
We do.
about what's going on, because you need solid data so that you can assess. I went to my doctor. He told me there's no such thing as adrenal fatigue. Well, your doctor may be a really good guy, but in general, the medical community does not. We just made the comment. There's a new group of codes out that will define what your disease is or what your condition is, which, by the way, runs your treatment. And we said, and then the new ICD-10s. There's like 10,000 of them, right? There's like
if you get impaled by a reindeer through the chest, there's an ICD-9.
There's a code for
that. Yeah.
But we're not sure. There may not be a code for adrenal fatigue. We'll have to
I
look
think
that
there
up.
is one, but then it's not really acknowledged. That's
Okay.
what I looked into.
Okay.
Yeah.
So we just want to make the point that, we want to make the point today that this is a serious issue and it should be acknowledged. And if it's not acknowledged, then it's not going to get treated, and it's not going to get treated properly. And so we're going to go over that.
And I don't know if there's been any time in healthcare where there's such a glaring problem that's not being addressed. Very similar to the leaky gut phenomena that's going on, where we attached 110 references to that broadcast a few weeks ago. And we do it not to be pedantic, but to show you as the audience that there's a ton of data there, and you're going to read things online from different websites disputing or debunking, quote unquote, leaky gut syndrome or adrenal fatigue. And so we're putting together these presentations so that you have the data as a patient, so you can make your own decision, an informed decision. If you get feedback from someone saying, well, adrenal fatigue doesn't exist, you can say, well, here's a broadcast I watched and there's 45 references. So why don't you go ahead and read those references and let's talk about it. Now,
so what is adrenal fatigue?
Adrenal fatigue.
Maybe we should have started with that. I'm just
have.
thinking maybe we should have said, and this is what adrenal fatigue is.
Right. So the adrenal fatigue broadcast overview is that your adrenals are a stress gland. They sit on top of your kidneys. Okay, that's why they're above the renal. So that's the term adrenal. So the adrenal glands sit on top of your kidneys. They're a stress gland. They're there largely to keep you alive. They produce hormones that if you chop your arm off and you're bleeding to death, that your body will instantly start to save sodium back into your circulation so you can keep blood volume as high as it can be. Also, the adrenal glands make cortisol. So cortisol is a very important hormone associated not only with regulating blood glucose levels, but controlling inflammation. And we find that when patients don't have cortisol, they'll die rather rapidly because it is such an important hormone. And then the adrenals also make DHEA, which is a testosterone derivative. So when we hit puberty, DHEA is largely involved in creating secondary sex characteristics, like a guy getting a beard and us getting hair under our arms. And then the adrenals also make progesterone and estrogen to a minor degree. So adrenals make a lot of hormones, and they're very, very important. But the adrenals are triggered by the brain. So the brain really controls the adrenal glands.
And this is why when I said earlier that the adrenals are not the right target.
Right.
This is kind of what I was referring to, because it's really the brain that's setting off the adrenals, that's setting off the cascade of biochemical processes that Dr. Gage just talked about.
Exactly.
This is big.
And so the brain sends signals down to the adrenal glands, both through chemicals and hardwired neurological signals, telling the adrenal glands to make certain hormones or to make certain chemicals. And let's just use chronic fatigue as an example relative to adrenal fatigue. So adrenal fatigue is this concept largely established in alternative medicine where patients were fatigued. They were exhausted. They had low stamina. They had low energy. They had low sex drive. And doctors started running hormone analyses on the adrenal glands and found that maybe their adrenal glands were not producing a lot of the hormones that I just talked about, like cortisol. And then they started doing studies relative to chronic fatigue patients, which back in the 1990s, no one really knew what to do with.
Epstein-Barr virus.
Epstein-Barr virus.
That was everybody had, which can contribute, but it's not. You can look at our chronic fatigue video.
Exactly. And so Epstein-Barr can be a piece, but then the adrenals became the other fixation. So then people said, well, chronic fatigue is all adrenal fatigue. And the point that you have to realize is that with the adrenals are involved in so many different illnesses and in a complicated fashion. And sometimes they are the primary problem, sometimes they're not. Sometimes they're a tertiary or a secondary problem. And that's kind of what we want to highlight, because if you go back and watch our chronic fatigue broadcast, you'll see that chronic fatigue can be associated with like 8 different things. It may be associated with abnormal bacteria in your gut. It may be associated with insulin resistance. It may be associated with autoimmune problems. It can be associated with the adrenal fatigue like we're talking about. It can be associated with Epstein-Barr. It can be associated with your mitochondria, which make your energy. Maybe they have a problem genetically or due to a previous viral infection where they're not functioning appropriately. So
diagnosed mismanaged thyroid.
Yeah, thank you. Sorry, I missed that one. Thyroid problem.
Like the number one.
Thyroiditis. So yeah, thank you. So yes, that's kind of the overview of adrenal fatigue. So because of that, because chronic fatigue really was the centerpiece of why so many alternative practitioners focus on adrenal fatigue and sent their patients back to their GPs saying, this person has adrenal fatigue, and that created kind of the war. But in today's, whatever you want to call this broadcast, we're going to go through a variety of illnesses and really show you how the adrenal glands, if not the secondary problem, are almost a primary problem in this whole disease pathogenesis, and why our focus really needs to be adrenal centric. So we need to really focus on the adrenals in order to better understand conditions like anxiety, post-traumatic stress disorder, depression.
Yeah, I mean, I would say it's mostly primary or secondary.
Mm-hmm.
I mean, it's just, you come in here and you start, people have chronic pain conditions. You start interviewing them, and I'm telling you, there's always some sort of a stress that perpetuated from the beginning. We've talked about verbal, physical, sexual abuse. I had one lady yesterday, she just said, now that you mention, I've had panic attacks since I was 4 years old, things of that nature. Though, as Dr. Gates is going to talk about, he doesn't have panic attacks down here, but I'm sure he can cover them now. Mm-hmm. These are all have adrenal function involvement. They all have adrenal function involvement. And then, as Dr. Gates said, that adrenal gland starts affecting a lot of things. If someone comes in here and women come in here for all kinds of female problems, okay? And we're not endocrinologists, okay? We're kind of functional endocrinologists, okay? And they're on their medications. And I say, do you have endometriosis? No. Do you have fibroids? No. Did you have cysts? No. Do you have anything wrong? No. I've too much bleeding, too little bleeding, on 12-day periods, 39-day periods, 24-day period, painful periods. I'm telling you, if they don't have, I'm just using this as one example, mm-hmm. if they don't have, I would say absent of pathology, this is going to be the problem. Mm-hmm. These stress mechanisms are going to be the problem in the fact that Dr. Gates talked about the DHEA, and he talked about the little bit of progesterone and estrogen that's made, and pregnenolone steal. Mm-hmm. There's a pregnenolone steal where ultimately the stress hormones are being made or the stress chemicals in the adrenals are being used to make stress hormones instead of female and male hormones. And next thing you know, you're all over the place. You're taking all these pills, and you have this very delicate, very precisely balanced biochemical environment in your body. May not seem so, but you do. And now you introduce an estrogen in there, or progesterone, mm-hmm. where it's not needed. And now you start really setting off a bunch of other imbalances.
That's a great point, and I want to hit on that.
Okay.
So I think you as the audience, we have a lot of people who love watching these broadcasts. That's not egotistical. I mean, we got a call this morning from someone from Washington, D.C. They say they watch every week.
And if you're watching, we're getting back to you right after this, exactly. Presentation.
And so I say that to say, for those of you who are really interested, get a piece of paper, pause the video, get a piece of paper, and you should draw this out, because if you really want to understand the adrenals, you need to understand this diagram. Because I have a lot of patients that say, I just don't get it. I don't understand why, I'm still anxious, and I don't understand why I'm still fatigued. I don't understand why I'm still urinating a lot at night. Well, let's draw this diagram, because this will illustrate it to you. So at the top of the page, write pregnenolone, or you can just write PREG, because pregnenolone is the gas for your adrenals. It is the fuel in the tank. When you don't have pregnenolone, you can't make other hormones. And so then I'll draw a line down from pregnenolone, and then write cortisol, and then draw another line out from pregnenolone and write DHEA. Draw another line down, draw progesterone. Draw another line down, write aldosterone. You may have to rewind that because I said it kind of quick, but you can do that with this video. Now, as Dr. Rutherford was saying in that perfect illustration, is that if you're under a lot of stress for long periods of time, there's a good probability that you're going to take all of your pregnenolone and put more arrows going towards cortisol, because that's where it's going to go. And there's a good possibility that when you're under stress for long periods of time, you can make lots of cortisol for a long period of time. But there's also a probability that you're going to burn out your pregnenolone at some point, and then you're not going to be able to make cortisol. And all the while this is happening, as Dr. Rutherford was saying, then your DHEA levels go down. So draw a down arrow next to DHEA. Your progesterone levels go down, draw a down arrow. And so now, let's say you're a 52-year-old female who's gone through a divorce, like so many of our patients, and you've been under stress for a long period of time, and you're raising 2 kids. Think about what's happening. Now she's going to go into menopause. She's been shunting,
which is already stressful.
Which is already stressful, that's true.
I mean, it's physiologically stressful. If you were in perfect condition, it's physiologically stressful on your adrenal glands. So now you're going to throw all this on top of it.
Exactly. Now you don't have any pregnenolone, you don't have any cortisol because you burn out that system. And now you can't make any progesterone or small amounts of estrogen or DHEA that converts into estrogen in a postmenopausal female. So now you get hot flashes. So what do? You're miserable. You go to your doctor and you ask for bioidentical hormone replacement therapy. And so now you're on hormones, which are going to increase your risk of breast cancer and stroke and things of that nature, which could be serious issues associated with mortality. So that's the adrenals from a glance, just with one little isolated example.
And if you're wondering why your neighbor's going through menopause and they're not having all the problems you have, it's because they're not stressed out.
Yeah, they have good adrenals.
Because they have good adrenal glands. That's why. This is so important. Just think of the number of endocrinologists who are throwing tomatoes at us right now, because that's the fact.
Exactly.
The fact is that the hormone replacement therapy model in our country is kind of not aware of this mechanism. Okay, and so it would be reduced, the number of hormone replacement therapy drugs that have the side effects that give you the predispositions to other untoward events would probably be reduced by, oh my God, who knows, 50, 60, 70% more.
Right.
So.
Yeah, and we've seen patients where they've been on the hormone replacement therapy for just too long, and sometimes we can't bring it back because their physiology is disrupted by them. But overall, I would agree. I'd say it's probably about 50 to 70% of patients.
Yeah, and I bring that out because our premise was that adrenal fatigue should be an accepted diagnosis. Yeah. And if it were an accepted diagnosis in that realm, there would be a lot more people who would be getting through this menopause issue, maybe without the medications. And I don't think even a medical doctor would argue that you're better off with less medications. They do have a term called polypharmacy. And I'm even not clear. Some people say it's 3 drugs. I've read where it could be 4 drugs. But beyond that, they concede that it's a problem. There are too many drugs are a problem. But yet it's the model. And it is the model partially because of certain things that are going on out there. One of them is the absence of acknowledgement of certain conditions that can be resolved, probably without drugs. In fact, eventually Dr. Gates is going to get to this. This mechanism Dr. Gates mentioned, when you have adrenal stress, when you have stress over a long period of time, and who is that now in this country? Like 75% of the people in this country or more have stress over a long period of time. This process is going to engage, and you're going to have adrenal fatigue to some degree. Okay, but the stress mechanisms are not acknowledged as what they cause. A lot of them are not acknowledged as an adrenal fatigue diagnosis. They're acknowledged as frequently a personality disorder. In the end, and in the end, what I was going to say is that the stress procedure, this stress device is really, it's a survival mechanism. Stress is really a survival mechanism that's only designed to be engaged for a short period of time.
Yeah.
And I've seen studies that say anywhere from 20 minutes to 30 minutes. I actually saw one that said up to 3 months, that you could be under stress for up to 3 months. Like these people who are, for example, the people in Syria but after that, it's a problem. It's a big detriment, and it puts tremendous strain on your adrenal glands. And now it will create the exact effects that Dr. Gates just outlined to you, and more that he's about to outline to you. And your adrenal gets fatigued. It's like been holding the weight up for 3 months, and for many of you for 30 years. And eventually the pregnenolone goes. And the next thing you know, this is a major, in my opinion and my observation, and I screen all the patients that come in here, this is a major player in chronic pain. And even when we were kids, I remember my mom, and she would go, that person got cancer and it's their fault because they were stressed. Now that's really not a nice thing, okay? But there was actually a finger pointing at that point. That patient shouldn't have got cancer because they were stressed. We even understood that at that point in time, okay? That's not the way it is. You're stressed, it breaks down your system, and this is the primary mechanism that does it.
Exactly. It's amazing what a blind spot this is. So take cardiovascular disease, for example, in our country. What do? Do we just pay attention to the heart? We pay attention to the heart, but we look at factors such as blood pressure, cholesterol, which is, we can go off on. But that is what our system focuses on, because these are other factors associated with the disease. Yet you take something like depression. And when we know what depression, one of the main factors associated with depression is that you have heightened levels of cortisol, and the adrenals don't stop producing cortisol, even if you put more cortisol derivatives into the system called dexamethasone. 30 to 50% of the time. Same thing is seen in anxiety. And we know that with depression, one of the main features associated with it is that, and you can go back and watch our depression broadcast, the fear center in the brain, it's called the amygdala. It's deep in the center of the brain, produces all these stress signals. It's firing off like a firecracker. It's sending input to a part of your brain called the hypothalamus that then sends signals down to your pituitary gland, which is the master gland in the body, which then sends signals down to your adrenal glands, causes you to make more pregnenolone, make more cortisol, and then the cortisol feeds back up to the brain, and it starts killing brain cells in your memory area. So for those of you who walk into a room and you don't know why you're there, you just can't remember names anymore, or you have to write down a phone number 3 times, this may be going on. And it actually kills brain cells in your olfactory area, your smell area of the brain. That's now been shown. Because we have a lot of patients who come and say, yeah, my sense of smell is bad, and they don't have Parkinson's disease, so you're just kind of wondering why. And the reason why is that the memory area of the brain is one of the critical areas of the brain, along with the smell area of the brain, that makes new brain cells all the time. And cortisol just is very, very negative towards new brain growth, new brain cell growth. And so that's depression and anxiety.
And really it affects, really, I don't hear this a lot, but really it affects long-term memory too.
Oh yeah, eventually, exactly.
Because basically you got your short-term memory, the hippocampus is getting killed by the cortisol from your stress, from your adrenal glands. And then you can't sleep because it messes up your circadian rhythm. It also causes your brain to go 1,000,000 miles an hour. So you're laying there, you can't go to sleep. You wake up in the middle of the night, can't go back to sleep. And how does short-term memory get transferred into long-term memory? By sleep.
Right.
So this is adrenals. This is adrenal stress.
Absolutely.
This is so cool.
It is so cool. It's so exciting because this is just, again, it's a...
I mean, this is what we do every day. And I mean, I'm telling you, it's amazing because one of the neatest things is people come in here and they think they're coming out here with some major personality defect. Anxiety. Oh my God, I had anxiety. You can see the guilt in the person's face. It's like, no, you got a bad frontal lobe. You have adrenal fatigue. Maybe you got Hashimoto's thyroid, but there's a chemical reason for you having anxiety.
Absolutely.
And this adrenal has a lot, this adrenal function, this adrenal fatigue has a lot to do with it.
And then what we're seeing with depression is that the longer it goes on, then the more likely you are to become adrenally fatigued. And those who have what are termed low cortisol awakening responses. So basically, if your cortisol is low in the morning, that means your adrenals are fatigued. And if you have that in depression, it means that most likely you're not going to respond to medications anymore. And you have a very, very poor prognosis in terms of your depression going forward. So it's so fascinating because you start out in this heightened adrenal state like we've talked about, and then your adrenals peter out, you have adrenal fatigue, and now that means you're more likely to have chronic depression. Yet nobody is looking at this. Nobody is treating this within our current healthcare system.
Well, they're treating it with drugs.
Well, yeah, they're giving you more drugs, which
And
they
they're
now
not
know are not going to
acknowledging-
work.
And the drugs are working here, not on your
Right,
adrenals.
exactly. And they're actually making new brain cells in your memory area trying to compensate for all the damage from the cortisol. That's the new finding.
Yeah.
So that's depression and anxiety. Then PTSD, for example. We have a lot of patients who come in with post-traumatic stress disorder. Most people have a concept of PTSD relative to military involvement.
Yeah, the Gulf
War,
Iraq War,
Iraq War,
those
Afghanistan. We see a lot of patients who have PTSD relative to childhood trauma experiences that we don't need to go into, but we've talked about in other broadcasts. And so what we're now seeing with PTSD is that actually rather than having increased adrenal function with cortisol, they have low adrenal function. So most of them are just completely burned out. But another interesting aspect is that offspring, so children of PTSD mothers or mothers who have PTSD, they actually have heightened cortisol through their adolescent years. And so we're seeing that there's a transfer of stress hormones from mom to baby through the placenta. It affects how the baby's brain is developing. And the data just keeps coming out. It gets stronger and stronger. One thing we do see with the PTSD crowd, though, I talked earlier about how there's a chemical signal that goes to the adrenals and there's a hardwired signal. The hardwired signal with PTSD does not seem to burn out. So PTSD patients make a lot of adrenaline, but through time they won't make enough cortisol because the hormones they seem to fatigue and peter out.
I don't know how long you want to make this presentation, but on that,
yeah, I probably need to.
On that note of the increased adrenaline, I noticed you don't have fibromyalgia down here.
I'm going to chronic pain next.
Okay. There you go.
Yeah, so that same mechanism is involved with fibromyalgia. So many fibromyalgia patients, a large percentage. The percentage in literature we feel is underestimated given how many we see, and if you ask the questions in the right way from a caring manner, what people will open up to you that they've never talked about before to any other doctor. And so we've seen a huge percentage of fibromyalgia patients who have been exposed to childhood trauma or other traumatic life experiences, and then what that does to this HPA axis, as we term it, so basically the brain down to the adrenals, the amygdala to the adrenals, and they make a lot of adrenaline, and that adrenaline basically makes their pain nerves more sensitive to pain. There's actually now a discussion even relative to cortisol, because cortisol is used as an anti-inflammatory. So if you have rheumatoid arthritis, you go and you get a cortisone injection, which is basically a cortisol derivative, and that cortisol is going to calm down inflammation. But they're seeing that with chronically mildly elevated levels of cortisol, that it actually makes the body more sensitive to pain. So this is a brand new
You said that.
Yeah, so this is very, very interesting.
Sometimes I get educated here along with you. But
well,
unfortunately, he's already given me all this stuff already. But for the fibromyalgia patient, this is the reason people can't touch you. And then you get you have pain sensor fibers. They're there for survival, so that you put your hand on the stove and you go like that. Okay, so you have pain sensor fibers. The adrenaline starts sensitizing those fibers. Now you start killing your brain with feedback of pain. Your brain now starts learning pain. Your brain now, this is the fibromyalgia patient. Every single fibromyalgia patient that has come in here and will ever come in here, this is part of your clinical picture. And then your brain starts losing the ability to filter out this pain from the stress hormone overfiring, causing you to be so sensitive. And you're not crazy. You're totally not crazy. You've probably been stressed. If you look back in your past, I'm going to tell you, he's kind. I do all the interviews. I can't remember the last time somebody came here with fibromyalgia. He wasn't either physically abused, verbally abused, sexually abused, had alcoholic parents, something along those lines, or maybe some massive trauma, like the Gulf War, like going to the Gulf War or something like that. But some trauma that they can go back to. And what happens is it sets this stress mechanism off. And I don't know how closely you're able to follow the anatomy of this, but when Dr. Gates talks about the amygdala, that's like the spark plug. That's like the fear center of your brain. Okay, so you go through this thing, it sets off this spark plug. Now it sets this whole mechanism off, which is supposed to be a survival mechanism for 30 minutes, except maybe the person who is bugging you or molesting you or verbally abusing you or an alcoholic is there for years. And now this thing starts growing, and now this circuit won't shut down. And now you have these stress hormones going out forever and ever and ever. That's only part of what's causing your sensitivity if you're a fibromyalgia patient. But it has many, many more implications in chronic pain, not just in fibromyalgia, but in, I mean, everybody. Peripheral neuropathy, people coming here for depression, anxiety, post-traumatic stress syndrome. Yeah.
I love it.
It's amazing.
I love it. And I need to add one more thing to your diagram. So you got your diagram out with the pregnenolone, and draw a full circle around all of that with the arrows. That's your adrenal gland. Now draw another arrow to the pituitary. So write pituitary, and then from your pituitary to your adrenals, write ACTH. That's the chemical that tells your adrenal glands to work. And then from the pituitary, draw a backwards arrow or an arrow to the pituitary from the hypothalamus, and then draw an arrow from the amygdala. So it should go amygdala to the hypothalamus, to the pituitary, to the adrenal glands.
He doesn't seriously think any of you are doing this.
I do, because I want you to get it. And I'm doing this because when people ask me questions, I'm going to say, go back and watch the video.
Okay.
And look at this. Now,
this is a good reference for our patients.
Exactly. So the hypothalamus sends a signal to the pituitary called corticotropin releasing hormone or corticotropin releasing factor. And then, as I said before, the pituitary talks to the adrenals through ACTH, which is adrenocorticotropin hormone. Now we're actually seeing that the amygdala makes corticotropin releasing hormone itself. So that's a brand new finding. So the amygdala, we just used to think was hardwired to the stress response, talking to the hypothalamus.
That's that fear mechanism we just said.
Talking to your fight response. We now see that it's creating hormones to elicit this whole response, which is super fascinating. Wow. Very interesting. So going on, alcoholism. I was talking to another, she's a psychologist on Sunday about her experiences with alcoholism. And she said, you know, I can help drug addiction. I can help all these other things. But alcoholism, I just have a really hard time with.
Very low recovery rate.
Very low recovery rate. And I said, you know, well, we're working with a few patients who have alcoholism right now, and it's very interesting because the adrenals are so heavily involved with alcoholics. What we see is that with alcoholics, their cortisol is high all the time. And the only way for them to get it down is to drink. When they drink, their cortisol levels go back to normal. Whereas the average individual, even though you may feel more relaxed when you have a glass of wine, it actually causes you to make more cortisol. So there's this tipping point transition for the alcoholic where then they go into this point where they're high cortisol all the time. Drinking is the only thing that brings down their cortisol, and that makes them feel better. And so we've worked with some patients who have alcoholism successfully at this point, and it's been kind of interesting. The only thing we're doing with them is really fixing their biochemistry. We're fixing their frontal lobes. We're fixing
Those are the ones who came and admitted they were alcoholics.
That's also true. That's also true.
We've had several that said, no, I'm not alcoholic. And they were alcoholics, clearly.
Yeah. So there's this other entity called burnout. So burnout is another questionable medical diagnosis. And burnout basically refers to patients who are, when you say somebody, they're burned out, these people are burned out. And what we have seen in the literature is that they have adrenal fatigue. Their cortisol levels are low, they're consistently low, and it's hard for them even to get it back up after they take a year off of work. And in Rob Sapolsky's documentary on Netflix, which we recommend all of you watch, it's called Stress, Portrait of a Killer. They go in and they look at people in the English civil service. And they profile one gentleman who's at the low end of the totem pole in the corporate world, so to speak. And so his boss is yelling at him all the time. He doesn't feel enriched relative to his work, relative to his efforts. And he was frequently sick. He had the most missed time from work. And this was seen across the English civil service. And then they looked at someone who was at the high end of the corporate ladder, so to speak. They're never sick. They're always healthy. Their cortisol levels are low. It's very, very interesting because what we see with these burnout patients is that they just stay burned out and they don't really seem to recover. In our experience, unless you go in and you actually use tools to rehab the adrenal glands. So I'm going to skip allopregnanolone. Maybe we'll do a separate broadcast on that. But really our experience with the adrenals is that you have to figure out the stress response. You got to figure it out. If we have a marital disagreement,
they might like to know how you do that.
Exactly. They have a marital disagreement and it's not being fixed, you got to get it fixed. So we refer patients to a psychiatrist, psychologist, hypnotherapist. We find the right medium for that individual. Or if you have childhood trauma, those things have to be dealt with. Or if you have generalized anxiety disorder, we have to deal with that. And frequently what we find with these stress-related conditions is that there's a frontal lobe component. Your frontal lobes shut off these fear responses in the brain. And what we found is that frequently these patients have poor frontal lobe function. They don't have a tumor, they don't have a stroke, but their frontal lobes are just kind of weak, if you want to think of it that way. We exercise the frontal lobes. We see a clinical benefit with that. And then we also will go back in and use strategies to build new brain cells in the memory area of the brain, in the frontal lobes, to keep shutting off these fear responses. And then after doing all that, then we'll go in and we'll look at the adrenals. But with all that being said, you have to consider what's messing up your frontal lobes. So if you have low testosterone and you're a guy, that can be messing up your frontal lobes. If you're female and your estrogen levels are off, that can be messing up your frontal lobes. If you have Hashimoto's thyroiditis or a thyroid problem that's being mismanaged,
blood sugar,
or you're taking thyroid hormone, but you don't have any active thyroid hormone because you don't convert it, blood sugar problems, obesity, gut bacteria. The data is all there. We have it all in our other broadcasts showing that these are the factors. If you want to draw a frontal lobe, under your frontal lobe, these are the factors screwing that up. They have to be addressed. Once you address them, you start strengthening the frontal lobe, and then you shut off the fear responses. Then you can go to the adrenal glands if you need to at that point and start using, we use supplements, we use herbs, we use botanicals. They're referred to as adaptogens. Sometimes we need to give patients a little extra oomph with other adrenal supplements to help them function better. And in doing that, that's how you really rectify this adrenal fatigue issue in our experience. And it can be rather powerful. So we don't approach the illness from, oh, you have depression, I want to give you this, because that's what our healthcare system has become. And that's why adrenal fatigue is not a diagnosis at this point, because they want to say, well, if you have adrenal fatigue, let's give you a drug, and then problem solved, then the doctor can be out of the office in 5 minutes. This is more complicated than that, but it's so pivotal to these chronic illnesses that we've outlined, just a few of them. I hope you can see, we hope you can see that this is pretty profound and it needs to be addressed.
Yeah, and this is like functional medicine and functional neurology at its best, really. Yeah. It's really, we did a blurb, we did a hangout. What are we doing?
Hangout.
What are these things? We did a hangout.
Broadcast, yeah.
On functional medicine and some questions about where it was going back in October or November. And we got some real interesting feedback on that. But because it really is about understanding the multiple vicious cycles, the multifactorial aspects of what people are coming in. If you got chronic pain, there is no silver bullet. We did that one too a couple of weeks ago. And if you have an adrenal problem, it's not just about taking an adrenal supplement, an adaptocrine, something along those lines. You have to, in the same way that in doing the brain, in doing the exercises of the brain, and if you're interested in those exercises and what Dr. Gates was referring to, you can Google neuroplasticity on our Power Health Talk site, and we have a whole hour on those types of exercises that correct the function of different parts of the brain. But this is why chronic pain has gone from when I got sick, and for those of you who have never watched this, I got sick. I got fibromyalgia, peripheral neuropathy, celiac, chronic fatigue, Hashimoto's thyroiditis. I have Epstein-Barr virus. And we stopped looking at that point in time. But when I got sick, there was, I think it was estimated to have chronic pain. The same agencies who get those numbers together, maybe 6 or 8 weeks ago, said now it is 130 million. And then since that time, some government agency has said it's 59% of the American population. This is why, okay? This adrenal fatigue is a huge, huge part of it, but it is one of, but it is a part of an entire system, and the entire system needs to be addressed, which is why we said at some point in one of our talks, the adrenals alone are the wrong target. You take care of the brain, you take care of all the other things that are affecting the brain and are putting stress on the adrenals. Now you take care of the adrenals and you can be well, and you can be well. And it's pretty amazing.
That is.
So, and just one last thing, some of you might be going, well, how do I find out how my adrenals are? There might be people out there who don't know what adrenal stress index is.
So one last piece on this. Yeah, salivary cortisol testing. here's another thing. If you take a salivary cortisol test to your endocrinologist,
They'll laugh at you.
they're going to laugh at you.
Right.
Whereas all these experiments from huge journals that we've attached, everything is done with salivary cortisol testing because it's been shown to be accurate and reliable. And also, you can't check someone's cortisol level when you're going to puncture them with a needle, because that stresses a lot of people out. So you're not going to get an accurate gauge. So it's just like, oh my gosh, how are we missing this boat so severely? So yes, you do an adrenal salivary index. So you put little cotton swabs underneath your tongue. We see how much cortisol is in your saliva, and you do that throughout the day so you can get a rhythm for the person and what they're producing throughout the day. It's a great way of testing hormones, because all hormones vacillate, they oscillate throughout the day. Testosterone's high in the morning, but it can dip and then it can go up. And so same thing with cortisol. So you got to get the rhythm.
Yeah. So it's a very simple test, by the way. You do it at home. You do it at home. You salivary test at home, you send it off to a specialty lab, and that's how you find out. So don't go to your doctors and ask for the blood test for cortisol.
Right. Good point.
So anyway, so that's it. So I mean, we really can't do this subject justice in the period of time that we feel people are able to endure us here online. And it's just such a huge subject. I can't tell you how important it is. I can't tell you. Everybody kind of gets it. The whole country is stressed out right now, but they really don't get what that means. And they don't get how that relates to the fact that they're now saying that 59% of the people, adults and children in this country, have chronic pain. And I'm going to tell you something. It's going to get worse because nothing is being done on a broad scale to reduce it. In fact, I would argue that the present day presidential elections are doing everything they can to increase it by simply making people stressed out and mad at each other and stuff like that. And believe me, it's just a cumulative thing. So just be aware that your stress is no small thing. If you are not able to go to sleep because your brain's going a million miles an hour, you wake up in the middle of the night and can't go back to sleep. If you're having panic attacks out of nowhere, if you're having anxiety, particularly if you're going like, why am I so stressed? I don't feel like a stressed person, but I'm like stressed and I can't stop it. You are experiencing some level of adrenal fatigue. You are there. That's just the basic physiology of it. So hopefully that will put some enlightenment upon your situation, or maybe some loved one's situation. If you want more data, Dr. Gates attached 45 peer-reviewed journal references. I know
46 actually.
46, okay. And just a little advice from someone who won't read through all those either. Like maybe if you actually are going to read those, maybe just access them and just read the conclusion, which is usually there's like one last paragraph after you've waded through everything else that tells you what the whole thing is.
But I will say sometimes the nuggets are in the body of it.
They are, but we're talking to largely a lay public. I mean, the professors and all that watch, they already know that.
That's true.
Yeah. So anyway, so next week, hopefully we'll have another exciting topic. And if you have any comments on this, please feel free to send them to us. We're always interested in your input. And we will see you again next week.
Yes. And if you have any other questions, go to powerhealthtalk.com. That's where the broadcast is with all the references.
Okay.
Okay. Thanks for watching.